internal medicine and pediatrics, and then went on to do a combined adult and pediatric hematology fellowship at UNC in Chapel Hill. He's our go-to. I've been at a couple of different institutions, and we have a very strong hemophilia program here. And so we've collaborated on a number of patients, including patients that have come in from outside of the area because of the program that Dr. Buckner has built. So he was kind enough to agree to join us this morning and talk to us about hemophilia and how this impacts various joints in the body and what's known currently about management of hemophilia in these patients. So Dr. Buckner, welcome. Thank you for being here and being a part of this, and we look forward to learning from you this morning.
Yeah, thanks so much. This is exciting for me to get to connect more directly with you guys. We share a lot of patients, and you make a big difference for a lot of our patients with what you guys do, and so appreciate the chance to connect. And I know we've got a handful of people from our center who are on as well, so hopefully we can have some discussion as we go. Please, anybody feel free to jump in and ask questions. I'm going to try to share my screen. Let's see. I do that. Are you seeing my slides now?
Yeah, it looks great.
Okay. And let me see if yeah, okay, looks like it's working. All right, well, very good. I think we're ready here. So we're going to talk this morning about joint disease and people with hemophilia, and really try to lead up to the work that we do together with you, with the orthopedics department, with the Foot and Ankle Center, and give you some background on why that occurs and why that connection exists, and then kind of our perspective on how we try to help manage things to reduce the risk of bleeding in our patients when they have surgery, which of course is important. So we will go through, unfortunately, early on a Monday morning, you're going to have to listen to me give a coagulation crash course, just some brief reminders of hopefully enough to help the rest of the talk make sense. Then we'll discuss what's known about joint disease and hemophilia and some of the impacts that has on our patients. Talk about arthroplasty, which, as you might imagine, in a rare disease population, there's very little solid evidence in the literature, but there's some. And then I'll give you an overview of the medical management perioperatively of our patients with hemophilia A and B. And we will be focusing specifically on hemophilia A and B today, though a lot of these principles apply to other patients with more rare coagulation defects. So here's our crash course. So this is the cell-mediated model or cell-based model of coagulation, and this is what really got me interested in this field way back in medical school in 2002 or so, and something that just kind of stuck with me and that I was really interested in. But this is too much for a talk like this. Even this simplified version is too much, and so we'll shift over to this schematic, which is what I use to teach all of our fellows, medical students, etc., the coag cascade. So maybe familiar to many of you. I'm too lazy to write Roman numerals, so I always switch to regular numbers. So these are the clotting factors, and this is the clotting cascade proceeding from factor 12 through the intrinsic pathway down to the common pathway 10, 5, 2, 1, and then factor 7's over here in an alternate pathway, or the extrinsic pathway. So this schematic is built this way to help us understand the PTT and the PT tests. We try to remember it using the small bills for the common pathway factors 10, 5, 2, and 1. You may notice that factors 3, 4, and 6 seem to be missing. They're not missing, they just go by different names and are not part of the schematic when we think about testing. But you can see there factor 3 is involved in this pathway. It's tissue factor that participates with factor 7. Phospholipid is necessary for multiple steps. And it turns out that factor 6 is just activated factor 5. And so those are not typically referred to when thinking about the cascade. The important points to know here: hemophilia A is deficiency of factor 8, hemophilia B is factor 9. Those are the two that we'll focus on. Hemophilia C is factor 11. You can be genetically or you can inherit deficiencies of any of these factors, but we'll be focused on 8 and 9 for today. And then to throw this in here, it may be pertinent a little bit later, but the protein C and S are work together as protein S is a cofactor for protein C. These are anticoagulants that we all have, so our endogenous anticoagulants. They inactivate or inhibit factors 5 and 8 after they've been activated, and so slow down clotting. Similarly, antithrombin exerts inhibitory effect on factors 2 and 10, and then tissue factor pathway inhibitor, TFPI, impacts factors 7 and 10. We'll mention these on one slide and just a little bit later. But that's the coag cascade, and that's what we kind of have in our minds. Again, when we're interpreting the PTT and PT tests. Very brief background on hemophilia. So hemophilia A, as we said, is factor 8 deficiency. Hemophilia B is factor 9 deficiency. We categorize these deficiencies based on their clotting factor activity levels. So a normal factor 8 or factor 9 activity is 100%. If you have mild hemophilia, that means your factor level is between 5 and 40%. Moderate is between 1 and 5%, and severe is less than 1%. And these really were created and correspond pretty well for hemophilia A and B to the patient's bleeding phenotype. And so those with severe deficiency have the most bleeding. Those with mild deficiency typically have less. We do see patients of all severities who eventually need orthopedic intervention, including arthroplasty. So it's not just our severe patients, though they certainly have more severe joint disease earlier in life. Be aware that there is the possibility of our patients having inhibitory antibodies. We just call those inhibitors. And those are antibodies directed against either factor 8 or factor 9, depending on what you're deficient in. About 30% of those who have severe hemophilia A will at some point in their life develop an inhibitor. Many of those are treated and they go away. Some never go away and they have to be treated with something other than factor 8. 3% of those with severe hemophilia B get inhibitors. It's much less common and much harder to treat than the factor 8 inhibitors. But the main point is that if someone has an active inhibitor, we can't use that corresponding factor for treatment and have to use a so-called bypass agent like factor 7 or Novo 7 or something called FIBA. Excuse me. So that's inhibitors. We do have some patients with inhibitors who've undergone orthopedic surgeries of all types. The final thing to say here is that the genes for both factor 8 and factor 9 are on the X chromosome, so these are X-linked disorders. Severe hemophilia A and B are much more common in males. You can see even severe hemophilia in females, but much, much less commonly. Most females that are affected by factor 8 and 9 deficiency have mild disease. So quick background history of treatment. So just to give you an idea, really leading up to the recent time period, the last 10 years, the treatments for hemophilia have really, really changed and exploded in terms of options. Back in the 20s and 40s and before, it was known, but not known exactly why, but that to treat a hemophiliac who was bleeding, that whole blood could be helpful. That was the only known treatment. In the 50s, fresh frozen plasma and fractionation of the blood was discovered. That was processed for making FFP was developed in the 50s, and factor 8 and factor 9 were first described back then. Judith Graham Poole in 1965 discovered cryoprecipitate. So cryo is sort of a byproduct of the thawing process or the freezing process for FFP that contains factor 8 and von Willebrand factor primarily, with a few other things. So cryo for a long time was used as a treatment for factor 8 deficiency. Factor 8 and factor 9 were first isolated and purified in the 70s though. And so this is Dr. Brinkhouse at UNC with one of the hemophilia dogs. A large part of what we know, especially this basic science, we know because of a colony of dogs with hemophilia in Chapel Hill. They still exist. They still participate in research. They're very well taken care of out at University Lake. The first dog, I believe, that was brought by a vet to Dr. Brinkhouse was an Irish setter. Hemophilia is seen and is similar in dogs as it is in humans. The first factor 8 and 9 concentrates were available for treatment in the 70s. And then unfortunately, with the advent of HIV and hepatitis C, those concentrated plasma-based products caused the infection of a huge number of people with hemophilia in the 80s with HIV and hepatitis. And many, many people died, somewhere between a third and a half of those who had hemophilia at the time, particularly severe hemophilia, died from either HIV or hepatitis in the 80s. So a huge impact on the community. In the 90s was when the first recombinant factors were developed. This is a picture of the first human to receive a recombinant factor 8 protein. Also occurred at in Chapel Hill at UNC. And there's a good story that I won't spend time on, but about him and the fact that these recombinant factors were, and many still are, produced in Chinese hamster ovary cells. And so some good hematology stories about that experience. And really, again, in the last 10, 15 years or so, the therapies for hemophilia, which we'll mention just briefly, have really gone well beyond these early plasma-derived and later recombinant factor products. By the way, we still use plasma-derived factor concentrates, but there's been no transmission of any virus since the late 80s because of the discovery of purification and sterilization processes that are still used today for those products. So our major principles of management of hemophilia in the clinic. So for patients with severe hemophilia, the standard of care is prophylactic factor. So these folks should be receiving factor essentially around the clock. So about 3 times a week for factor 8 and 2 times a week for factor 9. Standard half-life products. That is based on a randomized controlled trial that was done by Dr. Manko Johnson here in the 90s and early 2000s that showed that starting prophylaxis at an early age greatly reduced joint disease in kids with hemophilia. There are some patients with moderate and even mild hemophilia who also we put on prophylaxis because they have a more severe bleeding phenotype. The aim of that, despite the huge cost, the big impact on people's lives, having to do IV infusions 3 times a week for their whole life, is really to prevent joint bleeds and prevent arthropathy. Joint disease does occur despite this in a lot of our patients, but the idea is that it delays the onset and progression such that they don't need their joints to be replaced at such a young age, though many still do progress faster than we would like. Any bleeds that occur, we treat with therapy that we refer to as on demand. And so that's simply replacing the factor that's missing, factor 8 or factor 9. And depending on the severity and location of the bleed will vary the dose or the duration of that treatment. We also, of course, treat with factor in the perioperative period to prevent bleeding with surgical procedures. Really, any invasive procedure we at least consider giving factor, and certainly anything orthopedic and that invasive, we would proceed with the goal to normalize or really rebalance the clotting system to try to help prevent bleeding and make that patient as normal as we can from a hemostatic standpoint, so that you can proceed with your surgery, knowing that the patient is covered to help prevent bleeding. We are very careful about monitoring joint status over time, and so one of the folks who I think is on the lecture this morning is Sharon Funk. She's a physical therapist who is retired now, but she worked at our center for several decades, and she was really heavily involved in developing the systems that we use currently throughout the country and throughout the world, really to monitor our patients' joint status. Very detailed physical exams, really designed to detect changes that occur due to bleeding and repeated bleeds over time. We use this as among other things, to help us evaluate the quality and effectiveness of our prophylaxis therapy. And it's a big part of, when our patients come for their annual comprehensive hemophilia visits, one of the biggest things that they do is the physical therapy joint health exam, which we won't share the details of today, but it's a kind of a pillar of what we do at the HTC. It helps guide a lot of our interventions and helps us understand really when is it time to start to get imaging of these joints and when to consider referring to orthopedics. We also have a lot of patients with chronic pain because of this arthritis and arthropathy, and so we're pretty heavily involved, and this is my main focus clinically, as well as research as a researcher, is management and assessment of pain. And so of course we try to use a multimodal approach, including both pharmacologic and non-pharmacologic methods, and surgery is certainly a major part of pain management for our patients. So again, when we treat or try to prevent bleeding, what we're doing is replacing the missing factor. In many cases, there are, as I alluded to, standard half-life products. So these are factor 8 or factor 9 products that are either derived from plasma or recombinant products. Some of the names, I've just got factor 8 names listed there that you might recognize: Adbate, Recombinate, Xintha. The plasma-derived are ones such as alphanate and willate. We basically in this center try to stick with our patient's particular factor product when they're having surgery, and so we typically will have that ordered by the hospital ahead of time so that they can get their same product. Sometimes, certainly if it's an urgent procedure or the patient's already having bleeding, we don't have their specific product available, we'll switch to a different one. And it really doesn't make or shouldn't make much of a clinical difference. But we do, if we have lead time, try to stick with their particular factor product. There are now extended half-life products. This is part of the innovation that's occurred in the last 10 or so years. There's multiple ways to do that. If anyone's familiar with pegylation of proteins to increase their circulation half-life, that's been done with factor. There are also products that fuse the recombinant products with the FC portion of antibodies that increases the half-life. That should say factor 8, not factor 7. And there's one product that fuses factor 9 with albumin, and that also can increase the half-life. All of these medicines are intravenous, and so IV infusions are, for many of our patients, just a fact of life. Many of our pediatric patients learn to self-infuse at home when they're around age 9 or 10. Often that learning happens at Hemophilia Camp, which we just finished Hemophilia Camp a couple weeks ago. And except for a couple of years with COVID, that's been going on up at the Easter Seals Camp near Georgetown for a number of years here in Colorado. There is a new medicine, I'll discuss it in just a second, called emicizumab, and it's worth knowing about because it's different and a lot of our patients are on it. So a primer on factor dosing, this is what I teach my fellows. One way to remember this is that every unit per kilo dose. So if I weigh 70 kilograms and I get 70 units per kilogram, every unit per kilo raises the factor VIII activity by 2%. So 70 unit per kilo dose, which is not a dose we'd ever use, would raise your factor VIII by 140%. Factor IX, however, goes up by half that much, by only 1% per unit per kilo. So a 70 unit per kilo dose would only increase you, by 70%. So another way to remember that is here in this table. So if you have hemophilia A, that's factor VIII deficiency. If you want to take somebody from 0% to 100%, so that's full correction, the dose is 50 units per kilo. And factor IX, the dose is 100 units per kilo. Those are rules of thumb, and of course this is our main role, is to help guide factor dosing, but that's essentially how we approach this. The half-life of factor VIII is 12 to 16 hours, and factor IX is 20 to 24 hours, so the half-life of IX is a little longer. The extended half-life products for factor VIII are not very successful, so they're not really that extended. They're about the same, maybe 18-ish hours for some of the extended half-life products. For factor IX, though, there's been a huge increase. Those products work really well with half-lives around 90 or 110 hours. So that Idelvion that we mentioned here, I think the half-life is 106 hours or something like that. So those products last a lot longer. Our patients don't have to do infusions as often, like once a week instead of twice a week. There is a lot of variability in half-life among our patients, and so we often will test that when we're designing their prophy regimens. And during surgery, so it's pertinent here that I think, and many of us agree with this, that the half-life seems to be decreased during surgery, so it gets consumed more quickly. At least that's the thought of why that happens, and that's really based on knowing we fully corrected someone before surgery. They go in for a 3-hour procedure, and then when they come out, we check their levels again, and they're much lower than we'd expect based on their usual half-life. So that's why in our plans you'll often see, if the patient's in the OR for longer than 4 hours, go ahead and give a second dose of factor just to keep them nice and normal while you're finishing up that surgery. The more than 4 hours, that in my experience, we're usually talking about like a multi-level spine surgery or perhaps a big neurosurgery. Hopefully the joint replacements don't take that long, but I know that sometimes they can. Or if you're doing a bilateral procedure or whatever. So that's why that second dose is there. So back to emicizumab, the brand name for this is Hemlibra. So this is normal factor VIII's job. So remember that cascade that we kind of draw as a waterfall? That's actually not accurate. Factor VIII's job is really to take activated factor IX and pull it into right next to factor X. So if 9 is in red and factor 10 is in blue, so that then activated factor 9 can activate 10 and clotting can continue. So 8 is really just introducing these two proteins together. So it turns out that the distance between 9 and 10 when they're in this conformation is the same as the distance between the two arms of an antibody. So antibodies are of course shaped like a Y, and that distance happens to be the perfect distance for 9 and 10 to get together. And so back 10, 12 years ago was when this, I think, first got started, investigation into how can we make an antibody that will stick on one side to 9 and on the other to 10 so that we can take factor VIII's place. So eventually emicizumab was discovered. It is a bispecific antibody, and as an antibody has several characteristics that make it clinically useful. But the biggest thing is that if you have an inhibitor, if you have an antibody that takes out all of your factor VIII and makes it not work, Emi does not look like factor VIII, and so it's not affected by an inhibitory antibody or an inhibitor. And so really this was first developed to treat people with inhibitors, but it also works for people who have factor VIII deficiency without inhibitors, because again, it's simply taking factor VIII's place. We refer to it as a factor VIII mimetic. So why does this matter? So it is not intravenous. It's given as an injection under the skin. That saves a huge amount of hassle for people. It also has a very long half-life of 28 days. So it can be dosed every week, every 2 weeks, or even every 4 weeks. It does take 5 to 6 months to get out of the system once it's stopped. If it's stopped, our population of approximately 200 patients with severe hemophilia in our center, at least half, if not 2/3 of those people have switched over to imicizumab as their primary treatment or primary prophylaxis therapy. Bleeding, because the half-life is so long, we cannot get peaks. We do not see peaks of activity, and so we can't bump somebody's factor level higher with IMI. So you can't use it to treat acute bleeding, and hence you can't use it to treat around surgery, or at least not major surgeries. IMI gives us about the equivalent of 20 to 30% factor VIII activity. We want people to be closer to 100% when you're doing surgery. And so we still need to use factor VIII. And we use the same dose of factor VIII in someone that's on IMI because the effects are not additive. Factor VIII pushes IMI out of the way when it's in the system. And then once factor VIII is metabolized and eliminated from the body, IMI comes back in. So the effects are not thought to be additive. But you do have to remember that IMI, and our patients have to remember that IMI can't by itself treat bleeds. So some issues with IMI, some of these we've solved. So the IMI does interfere with the old school. I call it old because we've switched away from this test at UC Health, at UCH. But the kind of standard PTT based one-stage factor VIII test is interfered with by IMI. And so anybody on IMI, if you do a regular PTT based factor VIII, will have a very high factor VIII activity of 200 or 300%, and that's falsely elevated. It's an artifact. Because of this, and because we wanted to still be able to monitor factor VIII in our patients around surgery who are on IMI, UCH changed to a special factor VIII activity excuse me, test called the chromogenic factor VIII test in April of 19. And this was specifically because we monitor activity levels in our post-op ortho patients in particular, and we wanted to be able to continue to do that. So I think it's still the only lab, except maybe for one small coag lab, but the only lab that does that. So Children's does not use this, Kaiser doesn't use it. So anybody on IMI, if you want a factor VIII level, it needs to be done at UCH. You also need to know that you should not use FIBA. That's one of those bypass agents I mentioned, but FIBA should not be something that anybody gets if they're on IMI, unless it's under hematology's direction. There were some people in the clinical trials for IMI that developed blood clots, and all of them developed blood clots when they were getting high-dose FIBA. So that's not a medicine you would get or you would use unless somebody had an inhibitor. But because of that side effect, if they're on IMI, we put FIBA in the chart as an allergy so that no one gets it inadvertently. Again, factor VIII dosing is the same with or without IMI. There are a bunch of other therapies that are in clinical trial now. We're not going to mention them. I just put them up here to make me nervous about all the new stuff that's still coming. And these are the places in the pathway that we started with where those things have effect. Many of these new therapies are rebalancing therapies. So instead of adding a clotting factor, you're actually taking away the effect of an anticoagulant like TFPI, antithrombin, protein C or S. Here's protein C. So inhibitors of these processes are in clinical trial now, and figuring out how to manage surgery in patients on these drugs is a hot topic in hemophilia care right now, because that's going to be something new if they're approved in the future. All right, now on to the actual parts of these talks specific to perhaps what you do day to day, joint disease and hemophilia. So the epidemiology here is rather than dive into any specific numbers, essentially everyone with hemophilia develops some degree of joint disease. In general, the more severe disease and the more frequent bleeding that you've had in the past, the more severe the joint disease that we see. There is some difference in the different severities in which joint is affected. So the typical or classic kind of pattern is that in people with severe hemophilia who were not treated with prophylaxis as children. So prophy wasn't standard of care until the early 2000s for kids. And so many of our adult patients grew up without prophy and were just treating on demand. Some patients who are older didn't even have that option when they were kids because there wasn't effective treatment. In those people, the knees tend to be the most affected joints. And so we have a bunch of folks who've had knee replacements or other various knee procedures in the past. So it's really the knee joints that were the biggest affected. Hemophilia, by the way, I didn't mention previously, tends to affect the large joints rather than small joints. So knees, ankles, hips, shoulders, and elbows are the big ones. In patients with severe hemophilia who are on prophylaxis, their experience is more similar to what we see in our mild or moderate patients, and that's the ankle being the most affected joint. And so many of our patients have at least some degree of ankle arthropathy. I would say in our adult patients, it's got to be close to 80+% have at least some degree of problems with their ankles. And again, prophylaxis does slow that joint damage, but it doesn't prevent it altogether, except for a very few patients. The pathophysiology of hemophilic arthropathy is not well understood, but there are some proposed mechanisms that are being studied, and a lot of this being studied in those hemophilic dogs as well as mice. But the dogs at UNC tell us a lot about this work. So if you have hemophilia and you have an injury that leads to blood in the joint space, that leads to hemosiderin deposition and eventually a phenomenon of essentially triggering the synovium. When that happens, we see synovial overgrowth and neoangiogenesis in the synovium, as well as cytokine release following the injury and blood being in the joint. Cytokines, among other things, activate the monocyte macrophage system, which in turn release more cytokines. And both of these, the monocytes and macrophages, as well as the cytokines floating around, contribute to apoptosis of chondrocytes. There's also thought that free iron that is, or heme, that's released from the red blood cells that are being broken down, and some of the products from macrophages create free radicals in the joint that then, through the killing of chondrocytes, eventually leads to cartilage damage. Something, it's not well understood what really contributes to subchondral bone resorption and damage. There's work being done on the rank and rank ligand system and how that's involved in being perturbed and leading eventually to bone damage. Those together certainly can alter joint function and biomechanics. We have a lot of work being done here at our center on the biomechanical changes related to having hemophilic arthropathy. And along with the overgrowth of synovium and neoangiogenesis that occurs, all these things kind of feed back to increase the risk of bleeding into the joint again, and you have this vicious cycle of over time more and more damage occurring and leading to arthropathy. So that's a not fully understood pathways. It's kind of my simplified view of how this occurs. But the bottom line is kind of summarized here in this figure. The bottom line is that bleeding damages joints, and damaged joints hurt. So this is a really messed up ankle, which you all know better than I do. So pain in people with bleeding disorders is a big deal, a very high prevalence, especially in those who have joint disease. It begins in childhood, and often it's acute pain with acute bleed, but over time, as that joint damage builds up, it becomes more chronic. Our adults with hemophilia, particularly those with severe hemophilia, about 30 to 50% have some degree of chronic pain that needs management of some form. And pain, as all of you can imagine, is highly impactful for any person, and that includes our patients, leads to decreased quality of life, reduced physical function, reduced participation in social roles, being able to go to work, being able to go to school, and it has a strong association with mental health conditions like anxiety and depression. So like I mentioned in the beginning, we do use a multimodal management strategy in our center, really that focuses heavily on physical therapy and PT interventions. So stretching, exercise, manual therapy, balance training, using braces and other orthoses, assistive devices, all those things feed into a physical therapy program designed to help manage chronic pain. Lots of education about the neurobiology of pain and joint disease and hemophilia is also provided, and is really one of the pillars of pain management here. Our second piece of the tripod, which is very important, is mental health. So we have social workers as well as psychologists on staff who help to manage depression and anxiety in our patients. This is really key for managing chronic pain, and there are different methods for doing that through cognitive behavioral therapy, acceptance and commitment therapy, etc. So multiple approaches to managing mental health. And then of course the third, one of the third pillars of management is medical, which we'll mention in a second. We're also interested in sleep and sleep quality. So sleep is impacted by pain, but it also impacts pain. And so we try to think about a person's sleep hygiene and whether they might have sleep apnea and have other things that need to be treated to help with sleep quality. There are a million complementary and alternative approaches to pain management, and our patients, many of them try multiple of these different non-pharmacologic therapies. Many of them are successful, some are not. I have one patient who really, with the combination of joint replacement and Tai Chi, really changed his life about a decade ago. And so a lot of these work for a lot of people, but finding that combination is sometimes a process. Medications, you know, we prescribe both non-opioid and opioid pain medications depending on what's indicated. We're not going to go into that here. But really, for us, from my perspective as a hematologist, our surgical options, in addition to addressing functional limitations and anatomic changes that can be fixed, like a bone spur or something that's limiting a patient's range of motion, the primary indication for surgeries like arthroplasty in my patients is really to treat chronic pain. And so we try to delay surgery as long as we can. We know that there's a limited lifespan of the hardware that goes into joints, and so we want to delay it as long as we can. But oftentimes, we're kind of at the end of the road in terms of managing chronic pain and need to turn to you guys for help. The potential gain in function and what you can do in terms of how someone, what their gait looks like and what their range of motion looks like, also super important, but really in my mind is often a secondary and most often a secondary goal compared to the chronic pain improvement. So arthroplasty and hemophilia. So joint replacement, hemophilia A and B, knee arthroplasty over the years has been most common. It's what we're most familiar with. So we obviously are close partners with Dr. Hogan in your department as well, who takes care of our patients who need knee and hip replacements or may need knee and hip replacements. Historically, and this was true when I trained, chronically painful ankles were treated with arthrodesis. You all know that. When I was a fellow and even early on in my career as a faculty, I was taught my patients that our ankle arthroplasty or ankle replacement was not a good option. The technology wasn't there. We didn't have surgeons that were experienced with it. And so we didn't really consider it. I'd heard of one or two places like Georgetown that had done it, back in around 2010. And it was kind of a big deal for us to think that that might ever be an option. But we've now come to rely on the Foot and Ankle Center as being able to potentially offer this to the right patient if it's something that would help them. So for us as hematologists, it's relatively new. There is scant evidence, if you can even call it evidence, on this procedure. It's really limited to case reports, at least in the literature and case series. I'll review what I could find in just a second on ankle replacement. Hip replacement is also something that we see in our patients. In our patients walking around during their life, hip bleeding tends to be less common than bleeding into the knees and ankles. However, around the period of arthroplasty, bleeding after hip arthroplasty is more common after that surgery. But in day-to-day life, the knees and ankles tend to be the locations more commonly affected by bleeding, and hence hip replacements are needed less often. Shoulder replacements, similarly, even less common to get bleeds there unless someone's injured or does a lot of work, over their head or something, manual labor. And so shoulder replacement or shoulder repairs are less commonly needed, but we certainly do see that. And then elbow replacement, much more limited role, even though we have a lot of patients with elbow issues, but simply because those procedures, people are left with more functional limitations. And so I think ultimately avoid elbow replacement for those reasons, at least from my perspective. Ankle arthroplasty, so the outcomes, what do we know about the impact of this? I can tell you clinically that, in our experience, our patients who go have ankle replacements, it makes a huge difference. The gentleman I mentioned to you who does a lot of Tai Chi, he had ankle replacements, and that's what changed his life. He had the first one done and then had the second one done. And so he actually travels the country teaching other people with hemophilia how to do Tai Chi, really focused on using that as a pain management. But I don't think it would have been the same for him without his ankles. And so he's been super thankful for that. So from our experience, it's been really, really helpful for people. There is one report that came out, I think a couple years ago now, from Korea, of a series of 16 patients. They also looked at 13 patients who had arthrodesis, but focusing here on those who had arthroplasty of the ankle. Their preoperative 0 to 10 pain score, visual analog score, was 6.2, and then post-op was 0.8. So this is a marked decrease, and really there's almost no intervention that has a 6-point decrease in the pain score that I'm aware of. And so it's also a little hard to believe that post-op, these folks had no other joints that were really painful, because a lot of times, although the pain in the joint that was operated on gets better, their other ankle then hurts and becomes the primary driver of their chronic pain. But anyway, this is what they found in these 16 patients. They also saw a modest and not statistically significant increase in total joint range of motion. So this is both dorsal and plantar flexion, but some improvement, and that kind of follows with what I'm familiar with in our patients. We see some improvement, but that's again not the major driving factor. I'd be interested to hear what your experience is from your side of things. And then there was also some improvement seen in this foot function index, which is a scale that I'm not familiar with, but was in this study. So that not a lot known or proven yet about these procedures, but again, clinically, I can tell you it makes a big difference for people. Perioperative medical management. So now we kind of get into the meat of things from the hematologic side. There is not a lot of evidence. There's not a lot that tells us, what's the best regimen, what, clinical trials proving that this is the best approach. This is all based on experience and what we learn from mentors. So, Sally Stabler has provided hemophilia care here at CU for a long, long time. And I came here straight out of fellowship, and at UNC, we use continuous infusion around surgeries, a factor. And so that's one approach. But here we use bolus dosing. So I sort of had to relearn things when I got here. And so I learned from Dr. Stabler. And so a lot of what I do and a lot of the recommendations I make are really very similar to her and what I learned from Dr. Stabler. And that's kind of how it goes with managing surgeries in people with hemophilia. It's based on our experience because of the limited clinical trial and even observational data around the best practices. Well, there's really not even evidence showing that CI is better than bolus or that bolus is better than continuous infusion. And so we kind of just use our institutional momentum and stick with what we know. There are guidelines from the World Federation of Hemophilia. These are all based on expert consensus, which basically means what I just said. We just use it based on our clinical experience. But for major surgeries, using a higher dose practice pattern, which is what typically would follow in the United States, preoperatively or right before your surgery, I want my peak factor to be around 80 to 100. And then these are the recommended levels on post-op days 1 to 3. We want a higher factor level during that initial period of healing when the risk of bleeding is the highest. And then we go down, days post-op days 4 to 6 to a slightly lower level, and 7 to 14, retreating out to 2 weeks, a slightly lower level than that. So keep in mind that, just for perspective, remember that our patients with severe hemophilia with no treatment, their levels are essentially 0. So we're really fully correcting them initially and then gradually working our way down. I can tell you that we, and you may be aware of this, but we're quite a bit more aggressive than this in our institution. And instead of aiming for peaks of 60 to 80 in the immediate post-op period, we aim for troughs of that low. So we push our levels much higher than that, typically with our dosing, to try to keep the trough above 60 or even 80 in the very early time period. And that's really just, again, based on experience with lower doses and having people who have bleeds during the post-op recovery period. So this is an overview of the template that I use for ankle arthroplasty for factor VIII and factor IX deficiency. So knee and hip are a bit different, mainly because it includes tranexamic acid as a matter of course, but for ankles, I don't use TXA, at least at this point. But in general, this is what we're aiming for. We want 100 to 120% levels at the time of surgery. And so we give one pre-op dose. You don't need to build up with doses over time. You just need that single pre-op dose. Again, here, if because of that consumption of factor during surgery, even without levels, we don't use levels to guide this in the OR. If you're there for 4 hours, we have a recommendation in the treatment plans to give another dose of factor, which is half the first dose, or a 50% correction. The newer thing that I've learned to do in the past several years is to give that very first post-op dose the night of surgery. So 12 hours after the pre-op dose, we want to have a dose of factor in. This can create logistical hurdles, for inpatients and making sure that that order is in, as well as for people who've gone home after an outpatient surgery, reminding them that, hey, you've got to get your first dose at home tonight, and really getting started so we don't have an overnight low trough. We give a dose at 12 hours. And then the first 5 days, we do use dosing, this half correction every 12 hours. And really, we're not going from 0 to 50 with all these doses. The idea is we're trough should be somewhere around 50 to 60%. And so we're going up to 100% every 12 hours. We're bumping back up to that level. The second 5-day course, so day 6 to 10, we're switching same total daily dose, but doing it every 24 hours, which that lets some of the troughs get a little lower, but it's still the same total daily dose. And for the next through 3 weeks, we don't stop at 2 weeks with joint replacements. We do 50% correction every 24 hours, so slightly lower levels. And then we continue to treat for physical therapy sessions in our joint patients for 6 weeks. And we can go beyond that. If there's any concern about PT causing bleeds, we really don't want that. We don't want that to interfere with rehab of a joint that's been replaced. And so we're pretty aggressive. This is quite a bit more than what's done, at other institutions. Some do it this way, many do not, and they stop at 2 weeks or maybe go out to 3 weeks with PT. But we're pretty aggressive about this. Anytime someone's having something taken out, like a PICC line, sutures, or a drain, we want to make sure they've had at least a 50% dose that day. So if you're in between doses on once you're out here to every other day dosing, we go ahead and give another dose at the time of suture removal. Though I think that happens well before that time typically. So this is what our treatment plans look like. This is a factor 8 plan, the factor 9 plan. The doses will be different, of course, but this is what you'll see in the chart or something similar. Always remember that we don't waste factors, so sometimes we give more than the dose that's written here. As long as it's within 10%, we're good with that. The factor infusions are pretty quick. They're just an IV push, takes 2 to 3 minutes for those doses to be given. It does not and should not go on a pump, does not need to be on a pump. If the patient doesn't have a port, which none of our adult patients do typically, they may need a PICC line because twice daily dosing may be difficult for somebody that's doing it by a butterfly needle in the peripheral vein over and over. Some patients can do that, most cannot, and so many will need a PICC line placed so they can do their doses at home. And then we prepare, our job is to prepare the patients and have all the tools they need at home to be able to do their doses. Occasionally they need home health to come in to do their post-op dosing, but most patients know how to mix factor and give it through a PICC line or give it through a PIV while they're at home, which allows us to, and a lot of your ankle arthroplasty patients have now gone home the same day and done those surgeries as an outpatient. So other aspects and things to mention, usually we don't recommend post-op Lovenox, for instance, due to the bleeding risk, or aspirin, and so we don't do DVT prophylaxis in our bleeding disorder patients. If they're inpatient, we do like them to get SCDs, and early ambulation helps to reduce the risk of clotting. But because there is a risk of bleeding with those, we tend to avoid them. There's some evidence to support that approach. And then again, tranexamic acid, there is evidence in a study that we did here and just published of a reduced risk of bleeding after hip and knee replacement. That study did not include ankle replacement. I don't see as much bleeding, or at least feel like we do in ankle replacements, so we don't use tranexamic acid. We certainly could if that was something that is more standard for your ankle patients. We're happy to discuss that. Other practical things, we mentioned the PICC line factor. The patient should have that at home delivered and ready before you ever start surgery, so that they have what they need to continue their treatment plan. They'll need factor for drain or suture removal. And then pain control for the acute post-op pain, we typically leave that to you guys, to the ortho team, and then we kind of resume that once they get through those first few weeks of the acute pain related to surgery. Our physical therapists are involved post-op, can help either directly with patients or with local physical therapists who are taking care of people during the rehab period to help educate and provide a second set of eyes for our patients with bleeding disorders. We are certainly available to help manage bleeding that occurs from the medical side. These are our numbers during the day. You call the center. Here's the main number. Here's the nurse line. Night and weekends, our calls go through the hematologist that's on call at UC Health. That's through Amion. Here's my pager. You can get to me through Epic Chat, or if all else fails, my cell phone's there. Feel free to get in touch with me directly, even if it's not my patient, if it's one of our hemophilia patients. I'm happy to try to help if there's bleeding going on. Know that our records at the HTC are in Children's Hospital Epic. Usually patients that you see at UC Health, you can see their records using Care Everywhere, the records from Children's, but you can't see everything. And so it can sometimes be hard to find these treatment plans. We write them as letters in Epic. We send them to the surgeon. It should come to you as a fax or as an Epic in-basket message. We also send them to the patient. If you don't have them, just call us. We can get them to you easily. We do copy them, or at least we're supposed to remember to copy them to the patient's problem list, both at Children's and in UCH Epic. So if they're having surgery at UCH, they should have a treatment plan in their problem list. And if you don't see it there, always just call and let us know, and we should be able to find it. The pre-op factor dose, many of you know this, that's given immediately prior to surgery. We write the order for that at the HTC and in the patient's chart ahead of time. We talk to the pharmacy, we get all that set up. And then one of our nurses typically comes to the pre-op area at UCH if it's being done at Maine to infuse that medication for the patient. Pharmacy is always part of this. We make them aware ahead of time that we need the factor. All of this is why we insist on 2 to 3 weeks notice for any procedure. So patient can't call us and say, hey, I'm having my ankle replaced tomorrow. We'll say, we can't do that. We're gonna have to delay it. These we tend to not miss, but things like dental work, often we don't find out to the last second that somebody's having that done. The post-op factor doses, if they're inpatient, those are ordered by the hematology consult team. Anything else comes from the surgical or primary team. If they're at home, though, the HTC is managing all their outpatient factor as well as tranexamic acid if that's being used. So that's it. I have gone a minute over, but happy to answer any questions or any discussion that you guys have. Oh, and somebody told me 55 minutes ago that I was in presenter mode, so there you go. Sorry about that.
That was amazing and fantastic. Is there anything on the horizon for like blood transfusion that actually would alter the cell factors so hemophilia is actually cured instead of treated?
Yeah, great question. So I think on this list of stuff, and I totally glossed over because of time, but yes, gene therapy is being done both for factor VIII and factor IX deficiency. Here we go. Gene transfer. Here you go. So there are multiple different methods, but most of them use in vivo gene transfer. So that just means a single IV infusion of an adeno-associated viral vector that goes primarily to hepatocytes, so that then factor VIII or factor IX is produced. So your transgene is either the factor VIII or factor IX gene. There's one factor IX product that we expect probably this year to potentially be approved by the FDA for commercial use. That on average in the clinical trials resulted in long-term factor IX levels of 20 to 40% or even more. So it's not a full cure of hemophilia, but it certainly converts someone from severe hemophilia to mild hemophilia. Those patients will still need factor around surgery, just like our mild patients do. But as that gets perfected, the goal, of course, would be to correct someone to 100% and not need factor anymore. Factor 8 is a little behind. Maybe later in the year we'll see factor 8 gene therapy approved. There is one product that's pretty close, but yes, that is coming and will impact certainly how we manage these surgeries, particularly with our dosing of factor around them. Great question.
So Tyler, that was outstanding. Thanks so much for doing this and joining us. I'll just share anecdotally, the patients with ankle replacements, with hemophilia who get ankle replacements really do well. I mean, it's very impactful. You referenced one of the patients. We now have a pretty solid series that we should probably publish.
Yeah.
We also track all of our outcomes in sort of a registry system that we've developed that started in 2019. So we'll have pre-op PROs, and then we can compare the both pre-op and post-op to the sort of traditional post-traumatic or primary arthritis patients to see what the difference is. So I have my research meeting next, so I'll propose that as something we could work on, and would love to have you collaborate.
Yeah, that'd be phenomenal. I'd love to join.
Yeah, but I have to say that your team is outstanding. I think the experience, it's seamless from our vantage point. Patients, that like your nursing team is there to administer factor. You get the PICC lines to get patients discharged, at a reasonable time. So it's really been a great collaboration. We appreciate that. I have two questions for you. The first is related to that. One of the hats that I wear as the vice chair of quality. I know, what kind of procedures cost in general, and like an ankle replacement in a patient with hemophilia is many times more expensive than non-hemophilia because primarily of the medications. Is there, with these newer meds coming out, is there a movement toward a reduction in cost for the medical treatment? Because that I know is that's not a deterrent, but it's a factor. If you pardon the term. Yeah.
Yeah. It's a huge deal, and one that we, probably because, if it's, on paper, it is shocking how much this costs. A 6-week course of treatment like that, if we're talking about 40 some odd doses of factor, at $2,000 to $4,000 per pop, that is, or per dose, that is, kind of getting into the 6-digit figure for cost of just the factor around the surgery. So yes, it's extremely expensive. And of course, we occasionally have to fight with insurance companies about that. Unfortunately, the newer products are often more, not less expensive. So there hasn't been movement in that direction. Certainly something like gene therapy, once you get past the cost of whatever that single treatment is and you no longer need factor, if we get to the point where you don't need factor for surgeries, that would be a potential solution. But that's, of course, transferred and concentrated into the cost of gene therapy, which is estimated. People think that will probably cost around $3 million for that treatment, and we don't know how long it'll last. Is the duration of effect going to be 10 years, 20 years, 30 years, or 2? And so unfortunately, there's not a cost savings built in here anywhere. Some of the factors are a bit less expensive, and so there are things that other centers have done, like move toward using only one factor for surgery. Like they have one particular brand, and because they contract with that company, they have a deal on it and they save some money that way. But as far as the products themselves, they do not save money. Now, are they cost effective is a good question. And we have some data from our knee and hip replacements study with quality of life data, the EQ5D, that may allow us to get at, what is the cost per quality of life year gained with these procedures. But those types of studies haven't been done to really prove, what is the cost effectiveness of these surgeries. We just know that they're very expensive, but they really make a huge difference for people. They're life altering. And so, we fight for our patients to be able to get them, recognizing that it does cost the system quite a bit of money.
Yeah, and so far we haven't had we haven't anyone turned away because of the cost, but I know that that's been a consideration. Well, I want to be respectful of everyone's time. I'll pass my other question along by email.
Okay.
But does anyone else have a question for Dr. Buckner? Okay. Well, Tyler, thank you again. That was really insightful, and this was recorded, so it'll be posted on our Foot and Ankle website. If you have learners or fellows or colleagues that would be interested in hearing this overview, it'll be available to them, and certainly to the orthopedic world as well. So thank you again, Dr. Buckner, for doing this. Really appreciate your time and expertise and collaboration, and I'll wish everyone a great week.
All right. Thanks very much, everybody.
All right. Have a good day.
You too.